Society of Lifestyle Medicine. He has vast teaching experience and numerous publications and contributions to book chapters and modules, and he started the postgraduate diploma in lifestyle medicine at CMC Vellore. So his areas of interest are lifestyle medicine. Our first talk is by Dr. Thomas Lamb. He is the project coordinator for anti-venom research at the Myanmar Oxford Clinical Research Unit. He is the first person to be granted the Hamish Austin Foundation Fellowship and has published research in prominent medical journals such as the PLOS Neglected Tropical Diseases, the American Journal of Tropical Medicine and Hygiene, and Clinical Toxicology. His areas of interest include snakebite prevention and management, infectious diseases and microbiology, global health issues, and resource-limited settings. His topic for today is bedside tests for the assessment of snakebite coagulopathy, balancing practicality and precision in diagnostics.
Hello, so many thanks for inviting me to talk at your conference today. So my name is Dr. Thomas Lamb. I'm a consultant in infectious diseases in Manchester, United Kingdom. I also have affiliation with the Centre of Tropical Medicine and Global Health at the University of Oxford. And also I'm an honorary specialist advisor to the UK Health Security Agency, so our public health body advising on anti-venom provision in the United Kingdom. Just to further on that, I've got a real interest in snakebite, owing to some previous experience having worked in West Bengal for a year, in Bangladesh, and also in Myanmar. And I'm currently collaborating with Medicine Unit 1 at CMC Vellore on a snakebite study. So yep, I was very privileged to be asked to talk today on the subject of bedside tests for assessment of snakebite coagulopathy, balancing practicality and precision in diagnostics. And I'll do my very best to try to cover some of the key areas in this field. Okay, so we're going to start with an illustrative case. So this is a 23-year-old gentleman who's a farmer. He was collecting firewood in the forest in the lowland area in Myanmar called Magway, and he presented to a local district hospital 2 hours after reportedly stepping on a thorn. Presentation, his foot was swollen and painful, and interestingly, the admitting doctor described him as having a toxic appearance. But nonetheless, he was admitted to the ward, and we reviewed him on the ward approximately 4 hours later. So I was visiting the hospital with a group of local physicians, and he was there. So when we went to see him, he was hypotensive, tachycardic, a bit drowsy, GCS 14, and was complaining of abdominal pain. So we were all in agreement, didn't quite fit with the initial presenting complaints. There was more to this story than just the simple cellulitis. So we, as part of the further diagnostic workup, we did a 20-minute whole blood clotting test, which was positive. So why are bedside clotting tests important in snakebite? So first and foremost, they're used as a diagnostic test to distinguish systemic envenoming from non-venomous or dry bites. So what I'm alluding to there is that many patients with snakebite will present having had no envenoming at all. So perhaps from a non-venomous bite or a dry bite, and those patients do not require any further treatment. Just observation and then discharge once it's been determined that there's been no envenoming. Now, many patients who are systemically venomed will have no discernible clinical features. So perhaps, report next to no symptoms aside from the bite. However, they may well have a detectable venom-induced consumption coagulopathy. We know it's important to deliver antivenom as soon as possible, and this can be critical at preventing or avoiding sequelae of envenoming. So I'm thinking about neurological sequelae or renal impairment. And perhaps the most important thing, reason for why these bedside clotting tests are important is that the epidemiology of snakebite means that patients often are presenting to healthcare facilities that have got relatively low resources. So local public health centres or that do not have a laboratory-based clotting tests such as fibrinogen, prothrombin time available. And for this audience, why are bedside clotting tests important? Well, India has the highest incidence of snakebite in the world, has the highest incidence of snakebite deaths in the world. This figure is taken from a publication by Surawira and colleagues, and it really shows you the high areas of snakebite mortality within India, really focusing on quite rural states. And the areas in dark red represent an absolute lifetime risk of greater than 1% from snakebite. And for me, that's astonishing. That's a really high absolute risk of snakebite death. So, and Vellore, perhaps not the most, maybe illustrative of the good care patients receive in Tamil Nadu, but certainly not an inconsequential risk in Vellore. So you'll be familiar with this 20-minute whole blood clotting test and a little bit more information about that. So it's essentially a modified Lee-White clotting test, which was derived in the 1930s. The modified test, the 20-minute whole blood clotting test, was developed by Professor Worrell in Nigeria, and with the objective of a simple, cheap, and quick bedside clotting test designed to identify patients at greatest risk of spontaneous hemorrhage. It has since evolved, however, and it's now predominantly used to detect the presence of systemic hemotoxic envenoming in the absence of clinical features. And I add that second bit there, the absence of clinical features, because if there are clinical features of spontaneous hemorrhage, then we need not wait for the result of the 20-minute whole blood clotting test before proceeding with antivenom administration. It's adopted widely in many national guidelines, including that of India and other countries in Asia, Africa, and South America, and also supported by the WHO. However, I think it's safe to say there is a lack of consensus about what is the role of this test, what is the diagnostic test accuracy, and ultimately, how do we best use this test? A quick summary or recap of what it is. So very limited equipment required: tourniquet, needle, ideally a clean glass borosilicate glass test tube, and a stopwatch. So you collect 2 milliliters of blood and decant that into the clean, dry glass test tube, and leave that undisturbed for 20 minutes. And then after 20 minutes, you gently tilt the tube to determine whether there's a clot present or not. A clot would suggest a negative test, and the absence of clot would be a positive test. And it's a binary result, either positive or negative. So, what is the diagnostic test accuracy? So this is a question that I came to myself. I'm trying to determine a clinical endpoint for a clinical trial to assess an antivenom dose. We were quite keen to use the 20-minute whole blood clotting test, and we wanted to know how accurate is this. So I performed a systematic review with amongst colleagues there, and we found that the meta-analysis found that the 20-minute clotting test was 83% sensitive and 92% specific at detecting a coagulopathy, as defined as an INR greater than 1.4 or a fibrinogen less than 100 milligrams per deciliter following snakebite. So I've published the meta-analysis there for INR, but a very similar graph, a box plot, is present for fibrinogen in the publication too. It is critical that 20-minute whole blood clotting test is performed by someone that's just trained to do that test. And it's also that they follow a standard operating procedure. And remember that it is a binary result. It's a positive or negative. It's not a clotting time. And another key finding of this study was actually the sensitivity and specificity was significantly affected by prior antivenom administration. And in fact, the sensitivity and specificity dropped close to 50% if you were using it to determine whether the coagulopathy or the VICC persisted at 6 hours. So our conclusion would be that you should not be using the 20-minute whole blood clotting test to determine whether there has been adequate or sufficient amounts of antivenom have been delivered. So it's good for determining a coagulopathy or for systemic envenoming, but a lot less accurate at determining whether sufficient antivenom has been administered or not. So what are the other options that we have for a bedside clotting test? So conveniently for this talk, there's been a very recent publication, a scoping review of handheld point-of-care devices. So that's predominantly INR, but not limited to INR, also looking at fibrinogen degradation products, D-dimer, APTT, fibrinogen, so a number of tests. So actually, there's very little data in this area. There's only 4 small studies, 2 of which were case reports, looking at the role of point-of-care INR in snakebite and whether they correlated to laboratory INRs. And unfortunately, of the 4 published studies, they found that the point-of-care device substantially underestimated the INR. And the working hypothesis for why that is that the point of care devices use a thrombin substrate endpoint, which is in snakebite patients that have a highly depleted fibrinogen, that the actual substrate can still be converted by prothrombin, so therefore it gives a falsely low INR, however, in the presence of a very low fibrinogen. So many false negatives in these studies, and ultimately I think that's basically put people off from using them. However, the authors of this recent scoping review found that there are actually 17 commercially available point-of-care tests, and they do have different endpoints. Not all of them use this thrombin substrate endpoint, which is prone to the false negatives. And therefore, they do list a number of devices which do show some promise. So, for example, the micro INR, the coagSense, and the PL Mini handheld D-dimer reader, all avoid the thrombin substrate endpoints, and the authors suggest that these would be good devices to test in snakebite. It's important to say that we need to test them against a range of different snake species in a range of different countries, because different snake venom profiles affect the clotting cascade at different points. I would also add a caveat that they can be expensive, and the cheapest one on the market in this publication cost $500 for the machine and $2 for each test. So on top of that, maintenance is required. So that obviously will act as a barrier for many patients. Other tests, what other clotting tests are there out there? So CMC Valor has really worked on this previously, and Dr. Rachana Shenoy K, she's uploaded her thesis, the ProTIV study. And that a part of that thesis assessed the kaolin activated clotting time. So that is using a kaolin to activate a clot, and then that clotting time can be measured. Now that's so-called VMAC test, and it is, I understand, it's implemented in CMC Valor for a range of other pathologies. So Dr. Shenoy and colleagues looked at the VMAC test at detecting snakebite coagulopathy. Now, in this prototype study, the gold standard for coagulopathy was defined as an INR greater than 1.2, sorry, and the VMAC test detected this with a sensitivity of 93.8% and a specificity of, well, nearly 97%. And that was favourable to the 20-minute whole blood clotting test, which was very much in line with the meta-analysis mentioned earlier. So really quite promising results. And you can see there the ROC curve on the right-hand side. That is a really fantastic diagnostic test accuracy. I do want to just add a small caveat there that the numbers of envenom patients within this study was low, just 36 patients. So I think for validation purposes, that needs to be expanded. But no, a really promising test, the VMAC test. Just another mention there is that it was performed within the laboratory, not on the bedside, but the results are quick, with less than 5 minutes. So that shouldn't be shouldn't be a big deterrent. Now, again, moving on. So there have been a number of studies, I mean, many studies actually. This is just a small section looking at the role of thromboelastometry or thromboelastography, ROTEM and TEG, respectively. And these are really quite geographically spread. So there's publications looking in Russell's viper patients in Sri Lanka, in viper envenoming in Vietnam, in South Africa, and in Australia. And as I say, there were in fact publications from countries in Africa, South Asia, US, amongst others. So the ROTEM and TEG, it's a test that provides a graphical representation of the viscoelastic changes during clot formation. It's quick, it's dynamic, so quick, within 5 minutes you'll get a result. It's dynamic, it changes quickly, and it's capable of detecting very subtle changes to clotting formation. It can also provide a binary result if you want to avoid the concerns about the interpretation of the graphical change. The studies that I've looked at there, they correlate very closely with laboratory clotting factors, so actually show quite promising role in detecting snakebite coagulopathy. However, they are high cost. They cost a lot to purchase in the first place. They cost to maintain, and there is a cost of training for operating these machines. There is also a lack of understanding about the clinical significance of very minor clotting abnormalities, and whether that is sufficiently enough systemic envenoming to warrant antivenom or not. And that needs to be certainly studied in more detail. And the range of publications, I think there is a role for a systematic review of this published trial data, and certainly upscaled research project in this area. So it will represent a very good thesis project if someone's looking for one. Okay, so we've covered quite a few of the bedside or simple clotting tests available. Let's go back to the case. So on closer inspection, this gentleman, he did have 2 fang marks evident over his ankle on the edematous foot. He was administered 10 vials of Burmese pharmaceutical industry monospecific antivenom. He stabilized over the preceding 4 hours and required no further antivenom, although he did unfortunately become anuric, and that required 8 cycles of renal replacement therapy over the next 2 weeks. But pleased to say he made a full recovery and has no renal sequelae after follow-up at 3 months. So let's conclude this talk. So there, there remains a need for simple, cheap, quick bedside clotting test that detects systemic envenoming. The 20-minute whole blood clotting test, I think, has the wealth of publications to support its use, but we really need to be understanding the diagnostic test accuracy. And what I mean by that is that when interpreting the results, we have to remember that 80% sensitivity means that 1 in 5 patients with a coagulopathy will not be detected by this test. And the specificity means that 1 in 10 patients that have a positive 20-minute whole blood clotting test actually will have normal clotting tests. So where possible, I would do the 20-minute whole blood clotting test alongside conventional laboratory clotting tests. I would not use the 20-minute whole blood clotting test to assess antivenom response because we know that the diagnostic test accuracy is diminished. I would advocate for the further research and validation of particularly the VMAC test, the point of care clotting test identified in the scoping review that do not use the thrombin substrate endpoint, and also TEG and ROTEM need to be looked at in more detail. And another conclusion and a learning point, I think, from this is that the ProTIV study, from my understanding, was not published in a peer-reviewed journal, but it really should have been. You know, this is work that other centres could really benefit from, and I think well-designed thesis projects we should aim to publish in peer-reviewed journal so that other people can learn from your tremendous work. So well done for that, and thank you for listening. Very happy to take questions from the audience.
Thank you, Dr. Lam, for joining us online and for your talk highlighting the need for better bedside tests.
You're welcome.
I'm sure most of the doctors here in the audience would have managed patients with snakebite, and doing these bedside tests is something most of us would have done. So if you have questions, do put them up. So Dr. Lam, after the 20 WBCT, which is the next best test that we have available now as a point of care test?
Yeah, so a good question. I think the 20-minute blood clotting test is not the best test, but it's the most convenient, cheap, and available test, and we have a good idea about its accuracy. So I would say that it's not the best test. I think that the VMAC test probably should be looked at in more detail because it has the advantage of being very cheap and quick as well. Results are given, I think, within 5 minutes of it being delivered to the laboratory. So I would suggest that that should be expanded, but it clearly needs an SOP. It needs to be established within an institution. So there's no like any laboratory test, it needs to be internally validated. Yeah, I personally wouldn't use any point of care clotting device like an INR, fibrinogen, or D-dimer without, again, further publications on this area, because you really the the data at the moment, the published data around point of care INR tests is terrible. So they really shouldn't be used until a promising alternative is identified. So in short, yes, use the 20-minute whole blood clotting test alongside conventional INR if you have it available. The advantage of using them both is that the 20-minute whole blood clotting test gives you a result sooner, much sooner, and obviously antivenom administration is time critical. But I think Valor is a good place to really expand on that VMAC test, because you could ultimately find yourself in a position where you just replace the 20-minute whole blood clotting test. I hope that sort of covers the question.
Thank you. There's one question from the audience. Does the amount of blood taken affect the 20 WBCT result?
Yeah, I'm not sure that's really been looked at. Well, I mean, I know that some centers use 1 milliliter of blood. I think that was the standard of care in Sri Lanka. They seem to get very similar results. But I guess why is it clotting within the glass? It's being activated by the non-coated silicon glass. So you want to sort of standardize the amount of contact of the blood with the glass. So I would follow the recommendation which was published by David Worrell and has been replicated in the WHO. So I would use 2 milliliters in a plain glass test tube, which is uncoated, which are surprisingly hard to get hold of now, the uncoated borosilicate glass. Yeah, whether in practice does it make a difference? I honestly, I don't know that.
And there's one question. Do you think there could be differential performance of the 20 WBCT or other tools according to the species that is responsible for the coagulopathy?
Yes, I do. I guess it's a very crude test, right? So you're trying to determine venom-induced consumption coagulopathy. In my experience, that tends to be an all or nothing type of coagulopathy, meaning that the INR is either normal or it's above the range of detection, so greater than 12 or whatever assay you use. So there are some publications that we reviewed, part of the systematic review, that reported much lower sensitivity and specificity, but there were problems with their trial design, which meant we didn't include them in the systematic review. For example, a large study in India, in Sri Lanka, reported sensitivity down at sort of 65%, but the 20-minute whole blood clotting test was not performed simultaneously with the laboratory test. And we know it's a very dynamic process. Patients are presenting relatively quickly after snake bite in that hospital within 2 hours, median time of 2 hours. And the coagulopathy was changing rapidly. So with regards to different species, so there is a huge variety of mechanisms of coagulopathy varying on the different snake bites, but ultimately they lead to a depleted fibrinogen in almost all circumstances. So there was relatively homogeneity in the diagnostic test accuracy when we looked at the systematic review. So I would say it probably has fairly good efficacy across a range of snakes, but unless you actually test them against different snakes, we won't truly know the answer to that.
Okay, what's your take on the 30 WBCT? There seems to be some data suggesting its superiority over the 20 WBCT.
Yeah, I don't agree with that, actually. I don't think the studies have been done enough. I don't think they've been replicated in well-designed trials in a range of different places. So, no, I know people have looked at 10-minute whole blood clotting test, 20 and 30. I don't know. And we sometimes see that the clot that forms at 20 minutes is actually lysed by 30 minutes, so thus producing false negative results. So, no, I don't agree with that. I mean, and simply if that's a question which has been proposed, it needs to be addressed with a research, with a research question.
Okay, thank you so much, Dr. Lam, for your talk and for joining us for the questions. Thank you.
My pleasure. Thank you very much. And yeah, have a great day.
Before we move on to the next talk, we're going to have the prize distribution for the poster competition that was conducted last evening. I would like to invite Dr. Dilip Mathai and Dr. Hansdak to please give away the prizes.